Thank you so much for being in our session today, which is going to be on what's hot in gene therapy. As it was mentioned earlier by Dr. Cantor, who's going to talk to us more about gene therapy, that is the conversation of the day when it comes to sickle cell disease, are these new cell and gene therapies. There will be another session later today with two individuals that have undergone bone marrow transplant and gene therapies, and I hope that you can attend their session as well. But I'm going to go ahead and introduce Dr. Cantor. I've known her for quite some time and worked with her. And so Dr. Cantor is a lifespan hematologist specializing in sickle cell disease. She recently moved to Alabama to become the director of the Adult Sickle Cell Disease Program and co-director of the Comprehensive Sickle Cell Disease Research Center. Prior to moving to Alabama, Dr. Cantor was an associate professor of pediatrics at the Medical University of South Carolina, where I met her, where she developed the first all-age lifespan comprehensive sickle cell center. Dr. Cantor is very committed to improving outcomes in sickle cell disease and ensuring those outcomes reach affected individuals. So without further ado, I'll turn it over to Dr. Cantor.
I think everybody's going to be able to repeat that by heart in a little bit. All right, well, thank you again. I apologize again that you have to hear my voice one more time. But we're going to totally change topics and talk about gene therapy. Same conflicts of interest disclosures. Okay, so hopefully a little bit of pathophysiology, not too much, not going to put anybody to sleep. And then we'll talk about the FDA gene therapies. And I'm actually going to show you a head-to-head comparison that I don't think people have kind of recognized yet, and we'll talk about some of the barriers and the ways that we're thinking about optimizing this therapy for individuals living with sickle cell. So I think everybody knows this, right? Chromosome 11, that's where the party starts. This is where the mutation is that results in hemoglobin S. What's most important is at the site of this beta globin location, how many gene therapies are we using? 0. None of the gene therapies actually target the beta globin mutation. And so this is something that I think people don't completely recognize. And I know I don't see him here today, but one of the gentlemen yesterday asked a question about what direct genetic changes can we make to the genome? And the answer is we haven't done any successfully yet. So I'm going to explain one that was trialed and why it failed. But as of right now, we're not touching this chromosome. Instead, we're adding hemoglobin A genes using one type of therapy, and the other one we're editing with hemoglobin F on a different chromosome, at a different gene. So we all know hemoglobin's pretty awesome, right? It's really an amazing protein. It's oxygen sensitive and it carries oxygen. And there's actually about 2 trillion molecules of hemoglobin per red cell. So in my mind, I always pictured maybe 100 strands of hemoglobin hanging out in every red cell. I can't even fathom 2 trillion or what that looks like. But what we need when we think about gene therapies is more anti-sickling or non-sickle hemoglobin in every red cell. So when you transfuse somebody, right, you give them some red cells with healthy hemoglobin, but it doesn't change the hemoglobin that they have in all of their red cells. So when we think about gene therapies and adding new hemoglobins, we want to make sure they get into every red cell. Well, I think everyone's pretty familiar with this, right? We know that sickle cell is an incredibly complicated disorder that's more than just pain. And pain is important, but we were having this conversation last night. As severe as pain is not what leads to mortality. Mortality is caused by other parts of this disease. So as we think about gene therapy, we also need to think about improving more than pain, even though that's been the endpoint that's used thus far. The other part is remembering that not all pain is vaso-occlusive. And I think this is going to be something that I'm going to spend the next at least 24 months really focusing on, that we rephrase how we think about pain. All crisis should be an acute pain crisis, but not all acute pain crises are vaso-occlusive. And this is really important. When we took people with bone marrow transplant and looked at them after transplant, we found they still had pain. And when you talk to those individuals, they would say, it feels just like my crisis. I still think I'm having a crisis. It is still an acute pain crisis. They still need immediate, appropriate, equitable treatment. But if we had a targeted anti-sickling agent, it wouldn't work for them. Why? Because they don't make sickle hemoglobin anymore. And there's a lot of reasons they still have pain. So we need to separate out. We need to stop saying that all pain is vaso-occlusive. All pain is acute pain, and all pain should be treated, but not all pain should be measured. In fact, I'd like to stop measuring pain because I think I learned recently, I don't know if you all know this, the pain scale started by Purdue Pharmaceuticals when they made Oxy. That's where the pain scale came from. So let's move away from that. Let's think about treating all pain and measuring vaso-occlusion. We also know that we're not there yet. And so why do gene therapies offer such promise? They promise to improve these curves and slowly but surely move that curve over so we can expand the lifespan of individuals living with sickle cell disease. We also know a lot about this. We talked all day yesterday about standards of care, hydroxyurea, chronic transfusion for sickle cell prevention, specifically for stroke prevention, pain management, diet, hydration, mental health treatment, and then some novel treatments, initially voxelotor, L-glutamine, crizanlizumab, and there's at least about 30 other novel oral treatments currently being studied. Oops, except we took that one away. That involves a lot of discussion, some that I'm actually having as a point of disclosure with Pfizer, because I think voxelotor has a role, and it goes back to how we measure things and what we measure, and making sure that we get the right drug to the right people at the right time. And so it's possible we'll see it again. This is the process. So I give Bluebird Bio a lot of credit. I call them out all the time because they didn't give up on sickle cell disease. And I think this is so important. So when I started working with them, because I was leading a sickle program and a transplant program, and we started Group A, which we now call those first 7 people who got this therapy, it didn't work very well on a number of levels. But those individuals didn't make more than about 15% hemoglobin A. That wasn't enough. And it also had other complications. And we had to do bone marrow harvests. And you can imagine how awesome it was, taking people who have leg pain and putting them through intensive, repeated bone marrow harvests. It really wasn't very fun. Well, at the same time, we had thalassemia. Same treatment, right? They used lentiglobin for thalassemia, and their outcomes were much, much better. And this is where I give them a lot of credit. When they looked back and they said, wow, we don't have the same problems with thalassemia that we do with sickle cell disease, they could have washed their hands of sickle cell and said, this is too hard, it's gonna cost us too much money. And they didn't. And they refined that process, and we actually have the process now because of them. And I call them out because they've gone through such troubles, financially and otherwise, and I wanna make sure that we recognize that we wouldn't be where we were if it wasn't for them. They really did stick with it. So now what do we have, right? We now know we need to calm people's marrow down, and we have to start with transfusions. And what that does truly is decrease a lot of the inflammation in the marrow, and it decreases the amount of pre-committed erythrocytes. What does that mean? Right now, if you do a bone marrow biopsy on someone with sickle cell anemia, you're gonna find that many of their stem cells are already planning to be a red blood cell. They already know what they want to be when they grow up. And the reason is, right, they need more red cells. So when we did these first 7 individuals, we weren't getting good stem cells that could be any cell. They'd already decided to be an erythrocyte. And so when we gave them transfusions ahead of time, it calmed down the marrow and allowed those individuals to produce more pluripotent stem cells. Then we realized that apheresis was a much better option. Oh my God, was it a better option than doing these bone marrow harvests with plerixafor, and that we could do it safely. Not with GCSF and not with steroids, but with plerixafor. We made some slight adjustments to the busulfan, and then the company, Bluebird, really fixed their transduction process, the process by which they got that gene into the stem cells. I continue to call it the special sauce because I've never known what they did, but it worked. So we're gonna focus now on these 2 approved gene therapies. And I really should go back and point out, right, so here the only difference with Casgevy is that instead of hemoglobin A, instead of transducing those stem cells, they're editing them. Otherwise, it's the exact same process. Okay, so these are the papers I'm gonna reference. Remember, we talked about how chromosome 11 is beta globin, and that's where the mutation is. But this is actually where the magic happens, not chromosome 11. This is chromosome 2, where BCL11A lives, and it affects what happens on chromosome 11, but we're not actually targeting the genes right here That's where your sickle gene is, and that's not what we're targeting. We're targeting the gamma globin genes. And what it does normally is there's this huge complex of lots of confusing proteins that turn on and turn off fetal hemoglobin. And the best known one is BCL11A. And normally it turns off fetal hemoglobin because when you're an adult, hemoglobin A is what you want to have. So what instead we're doing here is editing BCL11A. Again, we're not editing chromosome 11, right? We're editing chromosome 2. That's going to actually allow us to turn fetal hemoglobin back on. So I also call this out to say that because we're not editing the sickle hemoglobin, people still make sickle hemoglobin. So we're not changing the fact that individuals with sickle cell post-therapy will produce sickle hemoglobin. They will just also produce fetal hemoglobin, and a lot more of it. So this is looking at Casgevy's early studies before they were Casgevy, when they were just exa-cel. And I always say the names exa-cel and lovo-cel because I cannot pronounce that very long name. But what we see here on the top graph is looking at the total hemoglobin, which is green, and then the fetal hemoglobin, which is blue. And so what you can see is that fetal hemoglobin is about 40% of that total hemoglobin in most of those people. Importantly, similar to some of the other graphs, and this pointer doesn't work very well, but at the bottom are months post-infusion, and what you don't see here, or I guess you do now, are the numbers of patients. So when this drug was actually approved, we were only at 27 months. So in other words, only 2 people had gotten past the 2-year mark when Casgevy was approved. These are updated results, so now we know a little bit more, and we know that it's stable. But it was approved before we knew about longevity. And we're still not 5 years out, we're at 42 months. And the bottom graph is just your hemoglobin F percentage. And of course, we saw clinically meaningful improvements in hemolysis and quality of life. This is the swimmer's plot that everybody's gotten very used to seeing. Each individual patient is on that y-axis. On the x-axis is time. The before is where all the blue dots are. That's before treatment. On the right side is post-treatment. And what we're showing you that you don't need to be too much of a statistician to realize is there's a lot less blue dots on the right than the left, saying that they had a lot less vaso-occlusive crises, as we're still calling them, post-treatment. But you see some blue dots. And if you actually go in and look at those patients and see when they come in and they present to an emergency department, you'll see that what they describe as acute pain crisis, their labs don't look like they did when they had a pain crisis pre-treatment. Their vitals don't even look like they did when they had a pain crisis pre-treatment. So we have to use that word acute pain crisis because it is acute pain. It needs to be treated. It's not vaso-occlusive. So 2 different things. But you can also see we don't completely get rid of acute pain, nor should we have expected to. But we do really an amazing job, right? This is just absolutely amazing. But it's also why we call it transformative, right? It's not 100% curative. We're gonna go back to that thought in a second. Now we're gonna switch to gene addition. This is where we're using a viral vector. It brings in a hemoglobin A gene to insert itself and make hemoglobin A T87Q. Again, not really touching that beta globin gene, so everybody continues to produce sickle hemoglobin in addition to hemoglobin A. Same concept here. We're looking at the total amount of hemoglobin A made post-gene therapy. On the y-axis is total hemoglobin in grams per deciliter in the English way of the US, right? And then on the y-axis is, the x-axis is time post-treatment. We're a little further out here. We have more individuals who had been treated at the time that lentiglobin was approved and became Lyfgenia. The orange is other hemoglobin, and the blue is our goal. The blue is hemoglobin A. And most people now have about 50% hemoglobin A by the time they get 5 years out. Some more. I have a couple of people who make between about 52 to 55% A and about 40% S. But again, that S is still there. What else did we see? We saw that 86% of people received this or achieved this very complicated definition of globin response that we're not really going to go into, but 100% demonstrated incredibly durable follow-up. And interestingly, even if you look in our group A, those first 7 people, the durability, which now these people are 10 years out, is still there. So they have very, very persistent expression, which is reassuring. We don't think this gene is going anywhere once it gets transduced into the chromosomes. There were some people with a stroke, not vasculopathy, so they didn't have any significant CNS blood vessel disease, but they had had a stroke. They were allowed on the trial, and none of them have had a subsequent stroke. This same swimmer's plot, except somehow it didn't get quite produced as well, but you still get the idea, right? More dots on the left than on the right, but you still see some acute pain crises that happened on the right. Some of these are what they called serious or severe VOEs versus less severe VOEs. It's a very slight difference in definition, but severe meant you were hospitalized, whereas if you just came to the ER, got pain meds, and went home, that was not a severe. And you actually find that in general, people did very well, and in fact, 94.7% had complete freedom from severe VOEs. That's important because that's the actual measure that is similar to the measure that Casgevy used. They used different measures, which we're going to go into in just a second. Right, again, highly transformative, most people without any pain events post-treatment. All right, so here's the fun part where it gets the rubber meets the road, the head-to-head comparison. So the first is looking at the population. You're going to see on the right is lovo-cel on this table, and on the left is exa-cel. And the population of individuals who were allowed or involved in lovo-cel was up to age 50, whereas for exa-cel it was only up to age 35. Inclusion-exclusion criteria, I actually didn't know this for a long time. People with chronic pain weren't allowed to enroll into exa-cel. So maybe not so surprising that they had less pain afterwards. Everybody could not come in if they had severe vasculopathy. That's a very firm exclusion criteria. We've already discussed the mechanism of action is different. One is gene addition, one is gene editing. And the other thing that's different is the type of hemoglobin made, right? One is making hemoglobin A, and one is making fetal hemoglobin. I don't think we completely know what those implications are, and we probably won't know for another 5 to 10 years, other than to say that as adults, our bodies preferentially make hemoglobin A, which I think suggests that's what we're supposed to have, but we won't know that for a while. Primary outcome, similar, meaning pain. I want you to know that that was not the idea of these companies. The companies didn't want pain as their primary outcome. Think about stem cell transplant just for 2 minutes. When we talk about an allogeneic transplant, a transplant from somebody else, all of the outcomes, first of all, were measured by a company that doesn't measure sickle cell disease. CIBMTR did all the data collection. They did a great job, but all the data they collected were in terms of transplant, not sickle. So if you look in their database and say, well, how many people who got an allogeneic transplant had acute pain? Nope, not in the data. How many had acute chest? Not in the data. How many had retinopathy? Still not in the data. They didn't collect any sickle cell disease specific endpoints when they studied allogeneic transplant. All they kept count of was how much engraftment they had and how much healthy new hemoglobin they made. Those are biologic outcomes. But yet, when we switched to gene therapy, biologic outcomes were no longer acceptable as an endpoint to the FDA. I think we could have a very long conversation about that. When the initial phase 1 to 2 lentiglobin or lovo-cel study started, biologic outcome was an acceptable endpoint. And at some point, it switched to vaso-occlusive crises as mandated by the FDA. So while we were initially studying biology, we're now sort of studying biology plus pain plus perception. Just something to think about. The other thing that these different companies did is really helpfully, not helpfully, defined vaso-occlusive event differently. So we know in general, right, the definition is pain lasting more than 2 hours that isn't identified from a different source that requires IV treatment. They use that same definition for the most part, but for Casgevy, they said any 1 year period of time would count if you were pain-free for any 1 year period post-treatment. So you could be pain-free from post-treatment 12 months to 24 months and then have 6 pain events and you're still counted as cured. What instead the lentiglobin group did is said we're going to define the period of assessment from 6 months to 18 months. So just some slight differences. One is a moving radar and one is not. All right, what else? So we talked about age is different, chronic pain was different, mechanism of action is different. Now when we look at the treatment and engraftment characteristics, this is what happened during the trials. And the most important thing to recognize actually is the cell dose. If you see on the left, the lovo-cel collected more cells, gave more cells back. Why? They lose less in the manufacturing process. So we collect all these cells and we send them off to a company where the magic happens. And the process of putting the new gene in the cells costs about 50% of those stem cells. The process of editing costs closer to 65%. So they lose more stem cells. They also take a little bit longer to engraft. We have a lot of theories behind that, but that's what we're seeing in that neutrophil engraftment time. And otherwise, they're pretty similar. The biggest difference being at the time of approval, the median or mean duration in follow-up was 35 months, about 3 years in lovo-cel, and only 20 months. I was shocked that they allowed a gene therapy to be approved when we had less than a mean of 2-year follow-up. Okay, so now we have to define the expectations, right? We have this amazing transformative therapy, but maybe we need to make sure that we're as clear as possible when someone is coming into this. And I think this will be years and years of study till we figure out how to do this best. But we start with defining what we think is success, and then we need to ask the people who get the therapy what they think will be successful. And I think it's something we need to really work on. This is the biology of sickle cell disease. It's endothelial dysfunction, it's sterile inflammation, hemolysis, and polymerization. We can measure every one of these things. We can measure the percent to which we fix all of these, but this wasn't the endpoint. And this wasn't always correlated with the number of pain events somebody might have post-treatment. What about organ stabilization, though? Is it enough if we don't let the cells sickle? Well, voxelotor will tell us that wasn't enough. So it also has to be that not only do they not sickle, but they deliver oxygen effectively, and they either prevent any worsening or improve any organ dysfunction. Some organs we know don't get better. Avascular necrosis is the best example. We know once that bone is dead, we can't fix it. But what about kidneys? And how much of the kidney worsening should we expect? What about the heart? What about the eyes? Can you have retinopathy post-treatment? These are all questions that we haven't answered yet. And until we answer those questions, I'm pretty committed to not calling this a curative therapy. Because until I know I can protect you from having a stroke, I haven't cured you. And then there's the functional definitions. Does quality of life get better? Does pain get better? Does fatigue get better? I have a wonderful woman, she's 32, and she underwent gene therapy with us. And not long afterwards, took her first full-time job ever, moved into her first apartment ever. Lots of firsts, we were super excited, and then realized that her full-time job was serving as an assistant first grade teacher. And she was really tired. And she was like, my fatigue isn't any better. I'm like, no, it's probably worse, you're a first grade teacher. So again, defining those expectations. And maybe she moved a little too fast. Maybe you need to do these stepwise. She was so excited, which was wonderful. But then when she dove into her first full-time job, she'd never had to work 8 to 12 hours every single day. I mean, that's exhausting. Everybody in this room can attest to that. So again, how do we define those expectations? I had a young man who also underwent bone marrow transplant, and I am convinced he thought that would mean he would get more girlfriends. He never said that, but I am convinced that's what he thought would improve his quality of life. And when that didn't happen, he wished he had his sickle cell back. So what did he do? He stopped taking all his anti-rejection medicine. He didn't get his sickle cell back, but he did get really bad graft-versus-host disease, and broke my heart. And so I'm committed in his name. He's still with me and slowly inching along, but he's blind in one eye from corneal graft-versus-host disease. But I'm very committed to figuring out how to fix those expectations so things like that don't happen. All right, so current data shows these gene therapies are awesome. They're improving outcomes, they're transformative. What do we know? They increase hemoglobin, they increase non-sickle hemoglobin, they almost completely normalize the biology. Not quite, both trials are still about 5% residual hemolysis. They decrease or eliminate painful crisis. They improve fatigue and other super important patient-reported outcomes. But what do we not know? We have no idea if they're going to protect against stroke or kidney damage or eye damage. I will tell you, it's public data that one of our patients who is in lentiglobin had progressive retinopathy and retinal detachment. But was that preventable? We have no idea. So is it something we should have expected or shouldn't expect? We just don't know. We don't know if the therapies can repair any current damage or how much they can stabilize them. And at the time they were approved, we didn't even know how durable exa-cel was. That's me in Bumblebee. I was actually really excited. This was a trip to Spain with my daughter. When it's even funnier, I was supposed to go to Nigeria. I couldn't get my daughter's visa, but then we had to use these airline points. I had a lot of points, right? So my daughter and I took a trip to Spain. Anyway, so we ran into Bumblebee in the middle of a little, patio area, and I was like, well, I always talk about transformative therapies. I got to get my own personal picture with a transformer. So these are transformative. I really don't like using the word cure. Cure offers more than we can deliver right now, and we need to be really careful. What I don't want to do with the sickle cell community is overpromise, and I want to underpromise and overdeliver, and so that's what my goal is when I talk about these therapies. We know there's a substantial transformative impact, but we also know that they require immense safety to give properly. So there's some other important complications or things to consider. It's very logistically challenging to give these therapies, and my friends in bone marrow transplant are like, psh, we do autos all the time, we know how to do this. No, you don't. And yeah, you manage pain, but you don't manage this pain. And you don't manage pain in people who've been taking opioids for 30 years. There's still an infertility risk. There's a huge cost factor that shouldn't be overstated. And we still don't know about long-term safety, right? We haven't done this for longer. We don't even have most people out to 10 years. So when I start thinking about giving this therapy to 2-year-olds, I start having a little bit of pause because we don't know. And should I be doing that to a 2-year-old when I don't know? Okay, so how can we optimize things? How can we do this safety? Have to start at the systems level. What does that mean? Well, there's an urgent need for sickle cell disease treaters and treatment centers to start being friends, to start talking to each other, because it's unbelievable how often they don't talk to each other. And there is an urgent need to say this is what you should have at your center to be allowed to give these gene therapies. We know these are one-time treatments. I've had a lot of patients leave, not a lot, but a few patients leave my office in tears. Somebody refers them to see me because they want gene therapy. They want the one-time treatment. And they learn that that one-time treatment takes 12 months, a lot of money, a caregiver, the cost of fertility. And so we have to be careful with our words. It's something I actually am trying to impress upon my community colleagues. I am happy to see anyone. I also want them out of your care and into mine, but details. But I want to make sure that you're referring them for the right reasons with the right plan and right understanding. So this was the problem. The sickle cell treatment group, right? The sickle cell centers, we know these people. We've been caring for them for however long. We're comfortable with individuals. And the stem cell treaters don't know them yet, and often really don't talk to each other. The only good news is more often than not, they're in the same system, so at least they can read each other's notes, but not always. Sometimes they're in completely different hospitals. And there's an urgent need to say, okay, we need to have everyone talking, because what I found is all these stem cell treatment places saying, we're curing you, and all of our sickle cell centers saying, wait, let's talk about real expectations. So we had to change that and make sure that there was no longer a line, but a continuum. So we also talked about yesterday and this morning the importance of working together nationally when we're thinking about giving this care, because we have to optimize resources and opportunities. And so the United States and in Canada is going to be very similar. Not every center is going to be able to do gene therapy, nor honestly should we all be able to do gene therapy. We should get some centers who are really, really good at it, and then be able to high throughput send people into gene therapy and back to their sickle cell doctor for the remainder of their long-term rehabilitation so that we can get the most people, the most therapies in the safest way possible. So when we developed NASAC early on, within a year to 2 years, we said we're going to have to set some rules, some guidance, some guardrails for these therapies. This is where you can find a center, and we will eventually have on here which centers we think should be gene therapy centers as well. I'm going to give you a clue, though. They're not the same as what the companies think should be gene therapy centers. So we set some standards, and we said, okay, this is one of our consensus process when we said who should be able to do this treatment. Some of it seems very obvious. The sickle cell specialist should lead that consent process, not the transplant physician. We know what's going to happen to their sickle cell disease. Most of my transplant colleagues have met 15 people with sickle cell disease. That's not very many. What we do actually in my center, I really like. We do 2 separate consent processes. I consent for the overall process. My transplant colleague does this is what you get during the chemotherapy, and this is what to expect from that. I like it because sometimes I think people don't listen to me somehow. And so they don't hear it from me. They don't hear, your mucositis is gonna be really bad. But they might hear it a little better from the transplant physician. And so there's this really nice relationship that we have, and sometimes we'll each pick up something we didn't pick up before. But the sickle cell disease doctor should not say, I've consented you, see ya. Not gonna work out well, right? Instead, I'm gonna manage you all the way through along with the transplant doctor. The transplant doctor shouldn't even come in until you're ready to collect stem cells. Who should manage your exchanges beforehand? Absolutely your sickle cell doctor. And you need a multidisciplinary group to say, yes, we all think this person should proceed. Because like my young man, who we eventually figured out thought he was gonna get his girls after his transplant, maybe we would have caught that if we'd had a better multidisciplinary team. Not necessarily to not allow the transplant, but just to level set and give better expectations. We also said you need certain personnel. And this is how one more way that gene therapy saves sickle cell disease. There are a lot of our centers that are like, we want you to do gene therapy. And since we want you to do this therapy, what are you gonna give me for that? That's what we get to say as the providers. Great, I wanna do gene therapy too. I need a psychologist, please. I need an extra social worker, please. I need an extra coordinator, please. That's how we bring in more resources to help the greater good. And that is really doable. And so that's why we've made sure to highlight some of those on here. Experience, you should not start doing your first transplants in people with sickle cell disease. That is not a great idea. If your center has never done a transplant, let's not start with people with sickle cell disease. Train, go somewhere. The doctor can come to one of many centers and learn how to do this. And then finally, going back to our picture before, it's the same picture, but now you have a lot more steps in between identifying somebody for treatment and getting them over to the stem cell doctor and back, and making sure that that long-term 15-year follow-up, is led by not just your BMT group, but your sickle cell disease group. My transplanter, even now, her name's Donna, will tell you the patients won't come back to see her, but they always come back to see me. So when we want to make sure that this follow-up is being done, who's the individual most comfortable with should be able to dictate that follow-up. Also, who's going to manage the pain meds post-transplant? Because many people have to be weaned off. We're much better and more comfortable with opiate management than most of our transplant doctors. All right, post-transplant. This goes to what I was just saying, the importance of sickle cell long-term follow-up with your hematologist. Also because, as I said, we don't know what conditions we're going to fix or not fix. So who knows the sickle cell disease? The sickle cell specialist, not the transplant doctor. They're really good if you're worried about graft versus host disease, but we're not worried about that here. And then, how do we identify the right individual? I do not believe every person living with sickle cell disease should get gene therapy for about 1 million reasons. The system can't support it, obviously. So in some way, and this will probably be true in Canada more than the US, we'll have to do some kind of a triage system. And we want to make it safe, fair, equitable, and all those things. So what does that look like? And how can we prime people with sickle cell for success? How can we make sure that, again, they're not going to be my young man who was really disappointed in his outcomes? So this year, we started talking about this at the Alliance meeting, and we put up a whole consensus process to say, who's the right person with what we know right this second? This could change in 2 years when we have a new therapy. But with these 2 gene therapies that require myeloablation, that cause infertility, that we know have severe mucositis, and that have constraints on how we collect cells, who is the right person to get these therapies so that we can offer them the most success? There's a few things that are come out. Most of these I can't tell you yet because we haven't had our final votes, but I can tell you age-wise, we do not recommend children less than 12 get these therapies unless they're part of a study. We haven't studied it. We don't know the long-term, the durability of this therapy. Genotype, we do not recommend people with SC disease get this therapy. We actually don't know if it might cause more harm than good. It desperately needs to be studied. And we need to hold our company's hands and toes and mouths to the fire to make them study it. Because the FDA didn't do us any favors when they gave us a genotype-free allowance. So we need to make sure we study things properly. And then alpha globin, everybody should have alpha globin sequencing because we know that people who have 2 deletions shouldn't get addition therapy. We also know organ function is important, and we have some standards coming out for that. Last but not least, we talked a lot about social, pain, and identity. Do you know who you are as an individual if we take sickle cell away from you? This has been a question that I obviously am not the one to answer, but we need to understand how to help people start to answer this question. And I've had people very honestly say, no, this is who I am. I don't want to trade it away. That is fine. You know you, and that is the most important. But you need to start to think about that before it happens so you can picture what your life might look like. And I think that that is one thing that we have to figure out how to approach correctly, because we don't know yet, and we, the doctors, aren't going to answer the question. It's going to be the patients who have the therapy. So we have to have data. It all goes back to having data, and you have to have comparative data. Who does better? Is it the person who gets gene therapy when they're 35? Or is it the person who starts hydroxyurea when they're 35? Or starts exchange transfusions? We actually don't know that answer, so we have to have comparative data. So we can't leave our data over here about gene therapy and the rest of sickle cell over here. It has to be combined into one data set. So we talked about why we're using gene therapy. We're talking about the approved therapies, what we know, what we don't know, why they're transformative, how we're going to optimize this to make sure people have the most healthy outcomes, best outcomes, and how to ensure people know what they're getting into. And I'm happy to take any questions.
So we'll go ahead and open it up then to questions. I believe this room might be small enough for you to just speak up, but I'll bring the mic around if it's not.
Thank you. That was beautiful. I'm always learning new things. I was wondering, the patients who still had recurrent pain episodes after the therapy, if there was a correlation of hemoglobin levels, if they had higher hemoglobin levels, and maybe some aspect of hyperviscosity.
So a great question to what we know about people who've had acute pain crises after. I will tell you, I don't know if it'll be selected, but we did submit a very in-depth abstract to ASH this year about that. No, it doesn't correlate with hemoglobin at all, and it doesn't correlate to the percent of transferred or of changed hemoglobin. Unsurprisingly, what predicts pain post-treatment is pain pre-treatment. The more acute pain someone has pre-treatment, the more acute pain someone has post-treatment. And there are very different laboratory findings in the post-treatment pain. So there's a lot to be learned, but that's the hint.
Yes.
Thanks so much, Julie. And I'm happy that there's no question that this is really transformative. And I'm happy too that we're still being guided in talking about field. My question is, for the cascading, where we manipulate BCL development, and you said the hemoglobin F was like 40%. I want to know how long have we followed patients for, and if that is maintained. And I'm asking that because when we look at patients in Kuwait, for instance, who have the Arabia phenotype, most of my patients would have like 20 to 30% fetal hemoglobin. And most of them have a mild phenotype, although some still have issues. But the thing is that even with that, when they get to adulthood, many of them have severe.
Yep, we see it too.
Exactly. So, but on the other hand, now I have patients who have like moving there for 30 to 40%. Those as children have absolutely no problems. But we still don't know, even with those,
Right.
if they could run into problems as adults.
So I have a couple of theories, and one is that in the population of individuals who have persistent fetal hemoglobin for various reasons, some of them start to lose that fetal for whatever reason as they get older. In some people, I think the endotheliopathy catches up with them. That low-level hemolysis, and I always, I describe a lot of vaso-occlusion as traffic on a road. But every time you get traffic on the road gets damaged. And over time, I think the blood vessels or the road get so much damage that there's more vaso-occlusion even with persistent fetal. And I do worry about that, because if you're taking somebody whose roads are already damaged and doing this, to what extent will you get a good outcome? We have watched them over time. There is persistence so far. We don't have anyone on, they're just now approaching with Casgevy the 5-year mark. There's also some concern that manipulating BCL11A could have unwanted complications with stem cell survival. The group out of St. Jude's has talked a lot about this, so we don't know about that yet either. It seems to be that when you get across the 40% threshold and pancellularity, you do get elimination of hemolysis. And I do think that that's a good predictive factor, that if you're not hemolyzing, your outcomes are going to be better, and there's a translation to that. But I think the rest of it remains to be seen. I also wonder if some people may not do as well with fetal hemoglobin from an oxygen perspective, right? We know fetal hemoglobin releases oxygen differently, and I don't think we have any idea yet. But if you actually compare the data side by side with the group from Cincinnati, who also did gene therapy, I'll think of the name of the company in a minute, they ended theirs. They did a gamma globin, lentiviral gamma globin treatment, and they were only getting about 20-ish% fetal hemoglobin. And then you looked at Boston Children's, that's now a CTN trial, the GRASP trial. They're getting closer to the 30s. And then you get to Casgevy in the 40s. You can see that that fetal does translate to how many pain episodes at least they have, fairly predictably. And I think you're going to see from the early data we have from the BEAM study or the Beacon trial, they've already presented at ASH last year and at EHA, when they're getting above 60% fetal, you can already see how much more transformative that is. But then you start wondering if there's ever such a thing as too much fetal. And so I'm sure that there's a happy medium that we don't know the answer to.
Yeah. Thank you so much for that presentation. I think we're at time because we have another session starting. But Julie will be around for the rest of the
little while. I might need a
for
nap.
a little while longer. Hopefully you'll be around at lunchtime for the session the poster sessions we have, and you can find her there to ask questions. But
And this is my last talk. You don't have to hear my voice again today. Just want to reassure everyone. Thank you very much.
Thank you, everyone.